Good morning. Thank you for the invitation. So I'll share a little bit what the literature says and what my experience is from injuries like this. We need to be aware of the anatomy of the biceps tendon. It's not a tendon, it's a combination of two tendons, one short and one long from the two heads, and they attach to different places. That's why you have partial tears. It's the biomechanics of the actual tendon that can lead to injuries like this. The short head attaches more anteriorly, the long hair more posteriorly, so the short head is a stronger flexor. And we also need to be aware of the zones of vascularity and the bursa, which allows, it engulfs the entire distal tendon, and it's that bursa that allows endoscopic procedures around the distal biceps tendon. And then there is a complete difference in the population. So complete tears are usually young, active, it's only men, almost only men. And partial tears happen not equally, but in both sexes. They're often the result of a degenerative tear. They're not something that happens acutely, even though partial tears of the short head can happen as an acute injury, but that's extremely rare as an injury. They're generally older patients because it is a degenerative tear. It's similar to impingement and calf tear instead of an acutely traumatized tendon. So you see, most of those chronic tears will happen from the rubbing of the tuberosity on the two heads, and they happen from lateral to medial as the tuberosity gradually chews the two tendons. There is a possible increased incidence where the two heads meet because they rub with each other. So almost all chronic tears will start from the center and gradually expand outwards. Acute short tendon tears are almost always anteriorly and then progress posteriorly. And there is a battery of tests. With the hook test, you can see most of the complete tears. When you have an acute tear, it's more of a similar thing to an impingement in the shoulder joint. So you need to irritate the tendon to regenerate the symptoms. A very good combination of tests is the hook test and the flexion initiation test, which is rather simple. All you do is you ask your patient to extend their arms, and if they can't start, it's the same as if they can't start the abduction when they have lost the supraspinatus. If they lost part of their biceps, they can't start the flexion. A combination of those two tests can give you almost 100% confidence that there is a tear of some kind into that tendon. And now to diagnose, you have two modalities. One is ultrasound, the other is an MRI scan. Both are not very accurate. The ultrasound is extremely useful. I tend to use for partial tears ultrasound a lot. It's not, but I'm not using the actual modality. We have an MSK radiologist that has a special interest in shoulder and elbow. So he's able to identify and diagnose partial tears and give us very good results. But if you don't have that, then you need an MRI scan. Now, the MRI itself is not very accurate. There is this FABS view, which you can discuss with your radiology department and ask them to perform it, which doesn't increase the accuracy of the actual MRI scan. What it does is it increases the inter-observer reliability, which means it's easier for us to see a tear if there is a tear. And you can see at the bottom, on the left side, the tendon is complete. On the right side, you can see there is a partial tear. And with the advent of 4D CT, you can increase the accuracy of the diagnostic methods, of the radiology diagnostic methods a little bit. So in this paper, you had a 33% increase of diagnosing partial tears from other diagnoses like tendonitis or arthritis in the area. Now, 4DCT has a lot of radiation, and I'm not sure it's needed, simply because you have two simple diagnostic tests, the flexion initiation and the hook test. With the combination of those two and a good ultrasonography, you can have a pretty accurate idea of what you're dealing with and make a valid treatment plan. Now, conservative versus surgical. In this group, they say that almost both of them are exactly the same. And it's quite a recent study, only 2020. But if we go really back, you see Gregory Bain had this paper which is very accurate and you can follow for your treatment. So they're not all the same tears. You need to quantify the tear and then make a plan based on what you have in front of you. And tears more than 50% tend not to do well with conservative treatment. And this is repeated across all the studies. The good thing, though, is that from this study you can see that you can wait, and the final outcome is not worse if you wait for a short period of time, even if you have a large tear in front of you, which means that you can start your conservative treatment, and if it fails, and you know you have a hook test and a flexion initiation test that are positive, and an ultrasound indicating, or an MRI indicating a possible partial tear, you can wait and then proceed to the treatment. If you decide to treat with conservative methods, injections are quite often what we'll do. It's extremely important to proceed to injections under ultrasound guidance. There's this really nice study in cadavers which identified most of the injections that you do blindly do not enter the bursa, and there's a high risk of injecting areas that are not relevant to the problem that you have. I tend to use PRP instead of steroids for any degenerative chronic tendon tears because of the apoptotic effect of the steroids. So if I inject, I prefer to do the PRP, which there is no real difference between all those things. And then, when you have partial tears, and if you are aware and able to perform an arthroscopic assessment, it's quite useful. You can see the distal biceps tendon on the beam, so that's the Bhatia paper. It's a very good paper and a series of papers, not just one paper. If you decide to go ahead and try something like that, the distal biceps tendon is still attached to tuberosity, so that's what a normal arthroscopy would look. But you need to be aware, if you decide to do anything like that, at the top you see a partial tear that is degenerative, so there's a little cave inside the biceps tendon, and at the bottom the tendon is torn anteriorly, which means that you have an acute short tendon tear if you see something like that. But the complication rate can be really high. So that's a cadaveric study at the bottom where you see the radial artery has been severed in A. In B, the ulnar artery has been injured as well. In C, the tendon is over the radial artery. And in D, the tendon is overlying all of the venous complex that you have anteriorly. So there's a very high risk of complications because what you have to do is dive under all of the blood vessels to reach the bursa, inflate the bursa, and then work in that interval. You can use the same open techniques that you're used to. Assess the tendon if you have a high suspicion of a partial tear, and repair it at the same time. So you don't have to do the endoscopic approach unless you are familiar with it, and you can use a single anterior short incision to get to the tendon, identify debride, and if needed, augment or do a complete repair. And any method you usually do will work with this, so you can use buttons or anchors, whatever you're comfortable with. That's what is important. So this would be an algorithm on how to treat those tears. If you have large tears, more than 50%, you can, because they have a very high incidence of failure, you will tend to proceed with a surgical treatment. Now, smaller tears or ones that you don't have an accurate diagnosis of, you're not certain there is a tear, you can start with injections and physiotherapy, and then if you can do, and you are able to do, you can do an endoscopic assessment and proceed to treatment as you would normally repair your tendon. And with this is one of the places around where I live. So I'm still near the sea. I haven't left that much. Thank you.